All right, so hi everyone. This is the second time I'm with you. I'm Dr. Yafell Serulle. I'm actually not currently at Lenox Hill right now, and there's a typo there, but I'm actually specifically located in Westchester today at Phelps Hospital, which is one of our satellite hospitals. And today we're going to talk about neuroendovascular cases. What I'm going to do, I'm going to go through a lot of the endovascular neurosurgery cases. What I did, I selected cases that we have done over the last year and that I think are pretty interesting. And, I'll have some interesting stuff to talk about. And of course, if you have questions, feel free to put it on the chat and I'll try to answer them, as much as I can. So I'm going to start with some clinical cases here. We're going to start with the guy who's 56-year-old. He came with worsening right-sided vision. His right vision was failing. Sorry about that. Okay, hold on. I'm sorry about that. Okay, so he got a carotid Doppler as an outpatient, which is an ultrasound of the carotid, and showed a right ICA occlusion, and he was sent to the ED for further workup. We also learned when we were talking to him that it wasn't only his vision, he also had right-sided neck pain, which had started about 10 weeks prior when he was at work, and he's a landscaper. This is the non-contrast head CT, which looked pretty normal to us. There's no abnormality right here. And then we did a CT angiogram, which is a picture of the blood vessels of the head and neck. And as you can see in the arrows, this is the internal carotid artery on the left side, which looks pretty normal. However, when you look on the right side, there's no internal carotid artery. When you go a little further up in the neck, you see that there is a tiny, tiny attenuated internal carotid artery on that side. However, on the left, everything is normal. And as I said, this was the side of his problem. This is a CT perfusion scan, which tells us whether there is enough flow going into the brain. And here what I'm pointing at, it's gonna be the right side, that same side where the carotid artery was almost entirely occluded. You see that there is not enough blood going into the right side of the brain. So we took the patient into the interventional suite, and then we performed what we call a cerebral angiogram. And then what this is, we're going through the patient's leg, and we bring a catheter into the right common carotid artery, and then we inject that common carotid artery. And what you see here is that the external carotid artery, which goes into the face, is good, but when you go into the internal carotid artery, you see what appears to be an occlusion. Although once you allow the contrast to go through, you see that the contrast does go through here. However, it's severely, severely narrowed. So if you compare these to the other sides, this is the left side, and you can see that on the left side, there is good amount of flow here. And this is the posterior circulation in the other artery, the basilar artery here that feels very well. So we have a diagnosis here of an arterial dissection, and we took the patient for an intervention in which we needed to restore the blood flow of this internal carotid artery. And what we did, we put a balloon, we inflated that balloon, and then creating at least a conduit to go through. Then we put a filter device to protect from emboli, and then we put a carotid stent through this catheter. And as you can see, the stent there. And then this is the post-stenting angiogram. As you can see that what we initially saw of a almost completely occluded carotid artery now is completely recanalized thanks to the stent that is right here. And this is now all the blood arriving in the patient's brain. So the symptoms were resolved right away, and this patient was, Just a day after that stent, he was discharged home. And then on the follow-up in the clinic, the symptoms were, he was symptom-free. So, classic case of an arterial dissection that is causing a lot of issues, and, it's being solved with an arterial stent. These dissections, what they are hematomas within the blood vessel, and what they produce is stenosis during, of the blood vessel, and this leads to, luminal irregularity and other problems. And the main issue is that these patients have ischemia. This can lead, of course, to a stroke. There's a cartoon depicting what happened to this patient and what typically happens in arterial dissections. You have a blood vessel that is pretty good, and then you have the intima of the blood vessel is affected, is lesioned, and then you have a hematoma here. And what happens to you then is that the vessel is filled with hematoma, and then there's very little lumen through which blood can flow. These are some examples of dissection. This is a normal artery, more or less, on the right, but here you have an arterial dissection on the left. So the treatment, we typically can treat with medications such as aspirin or Plavix. Sometimes we use anticoagulation like heparin, but in some cases, we need to pursue a more interventional treatment, more invasive treatment, such as a stent, which is what I described in the prior case. It's really a case by case and depending on the severity of the case. And this is the classic case of a stent, another carotid artery here, showing an area of significant narrowing. And then this is the post-stenting. We can put a stent from this segment to this segment and then cure that narrowing. Very safe procedure when done the right way, and has a lot of potential positive impact in a patient. So going to the next case, we have a 70-year-old male with a sudden onset of left-sided weakness, which had improved once the patient had arrived into the ED. This patient had no significant past medical history. So left-sided weakness, which had improved by the time he got to the ED. We did a CT angiogram of the head and neck, and what we saw again in this patient was an area of a lot of vessel irregularity. You see, blood vessels need to look like this. When you put contrast in the vessel, it should look smooth. It should look like a tube, basically. But when you get to this level, you see that there's some filling defect here in this area, and then distal to it, you see the vessel, which is normal again. So a little confusing here. We don't understand what's going on. We see again in some axial views of the CTA, again, that filling defect right here, and this vessel is not completely round and regular. We did an MRI, which is a picture of the brain here, and this is specifically a sequence that is called diffusion weighted sequence, which tells us whether there is a stroke or not. And here, these bright dots here, what this means is that the patient is having small dots of infarct. These are small clots that the patient has had in the right side of the brain, which is the same side where this filling defect. So, so far, the last piece of evidence that we need to know is to kind of like look directly at that blood vessel. So we brought the patient to the interventional suite, and again, we put a catheter in the right common carotid artery right here. We injected contrast, and we saw this thrombus in the internal carotid artery. If you remember from the anatomy from the prior case, you have the external carotid artery, and then you have the internal carotid artery. And then you have this filling defect with the thrombus. And we know already because of the MRI that this thrombus is not very stable. In fact, from this thrombus, this guy threw a few tiny pieces and caused a stroke. So then what do? We always face these questions in clinical medicine. What do we do? Do we have to treat this patient with medications, such as antiplatelet medication, such as aspirin or Plavix? Do we anticoagulate the patient with heparin or Coumadin? Or do we bring this patient for endovascular treatment and put a stent? Or finally, the final option, do we take the thrombus out with a surgery? So these are, tough questions, because sometimes the answer is not that clear. Here in this case, we knew there was a thrombus. And we knew more than that the thrombus was unstable, was throwing already pieces of clot. However, we also knew that the patient was doing fine, that he wasn't that severely sick, and that he probably got to some sort of plateau. So here what we decided was to at least give it a shot to anticoagulation, to start the patient on blood thinners and see if the patient would do well. There is some data that when we treat these patients with anticoagulation, we are able to dissolve the clot or the thrombus in this case. So we went on and did the anticoagulation. And what we did, we repeated the imaging. And as you can see now, look at the artery, internal carotid artery on the follow-up imaging. It looks pretty good by now. So this is 2 weeks post anticoagulation. Now, if you compare that to what we had before, which was this irregular artery, now compare that to after 2 weeks of anticoagulation, that the artery is much better. And, sometimes, we don't need to do intervention. Sometimes the answer is not surgery or intervention. Sometimes the answer is medication, like in this case. Let's move on to another somewhat similar case. This case was a 69-year-old female who had recurrent episodes of left arm weakness in this case. And we did a CTA, and the CTA again showed us severe narrowing of the cervical right ICA with an associated aneurysm. We brought this patient to angiogram, and we see again a picture of the common carotid artery, the internal carotid artery, and the external carotid artery. So what do we see here? Well, there are two main findings. There are a couple of interesting findings here. You see again a thrombus. You have a filling defect, which is a thrombus right here. And then we have another finding, which is a pseudoaneurysm. This is an aneurysm that forms in the cervical, internal carotid artery, and then you have also a plaque here. So several findings on a patient who's having recurrent symptoms, and this aneurysm here looks like a heart, as you can see there. We did an MRI, and again, by now you probably understand this image. This is a diffusion weighted sequence of the brain showing multiple areas of acute infarct here in the brain. So these are small strokes in the brain. So we have a smaller strokes. We know that the patient has a thrombus right here, and we know that the patient has a pseudoaneurysm. So options, what do we do again? Can we save the patient with medications such as antiplatelets or anticoagulation? Do we need to stent the patient? Or does this patient actually need surgery? Well, the first thing we did, we know it's worked before, so it should work again. We tried anticoagulation, and anticoagulation actually got rid of this thrombus. So this thrombus that we saw here, similar to the prior case, we treated the patient with anticoagulation, and the thrombus was dissolved. So we solved one problem. We were left with another big problem. What do we do with this pseudoaneurysm? The problem of leaving this pseudoaneurysm there is that the blood is gonna stagnate here. And again, the patient can form this thrombus. So what do we do for that? We have two options for this. We have an endovascular option, in which case we can put a stent that goes from here to here. And this stent would exclude the pseudoaneurysm, or we can do a surgery, a bypass surgery, in which we get rid completely the segment and we do an end-to-end anastomosis here from here to here. In this case, because the patient had this big tortuosity in the blood vessel, we decided against an endovascular option, against a stent, and we decided, for surgery. And we did surgery, we took off this, and we did an end-to-end anastomosis, and the patient did very well. But you know what? For this thrombi, sometimes medication is not enough. This was a case we published a couple of years ago. And you see an ultrasound showing a thrombus in the common carotid artery. You see, arteries need to look like this. As I said, tubes where blood is flowing. Here, this is blood flowing, but then, bam, you bump into a thrombus. So this thing is there, occluding the passage of blood. These are CTA images again. Look at the common carotid artery on the right side, which is completely patent. And look at the common carotid artery on the left, and what do you see there? You see a filling defect. So this is a thrombus there. This patient was having recurrent symptoms as well. And in fact, we did an MRI. And again, this is a diffusion weighted sequence where you could see acute stroke in what we call a watershed area. This is the area of watershed distribution. So when you see strokes like this, what does this mean? This means that you are not bringing enough flow to the brain. So what we did? Well, we brought a catheter into this area of thrombus, and we started aspirating that thrombus. And you can see here the large burden of thrombus right here compared to here. So this patient did very, very well after that with just aspiration. So important to understand the disease process when you're dealing with these cases. You have to consider all management possibilities. For every case in vascular, neurosurgery, there's always going to be the possibility, or sometimes medical management, sometimes endovascular, sometimes open surgical option, and you need to weigh the risk and benefits of each approach and try to pick what you think and what the team thinks is the best approach. And that typically leads to successful, outcomes and to good outcomes. And of course, what's more important in the end, which is saving patients' lives. Let's move on to some more cases. We have a 67-year-old female who had a sudden onset of a right-sided headache. She had right-sided posterior headache, which was radiating to her neck. And then it was of sudden onset. And she said it was the worst headache of her life. So for all of you who are, somewhat familiar with medicine, all of these are buzzwords for something. When a patient tells you that the patient has a sudden onset headache and that is their worst headache of her life, what do you need to be worried about? You need to be worried about bleed in your head, specifically an aneurysm which has ruptured. So in this case, we did a head CT, and surprisingly, the head CT was normal. We did not see any blood in the head. So those are good news for a patient because, with that history, we will be very worried that the patient will have a bleed. In this case, the patient did not have a bleed. However, we need to have a very low threshold of suspicion in these cases, and we cannot just stop with the head CT. If the patient gives you that history, you need to be worried about an aneurysm. So what do you do to determine if the patient has an aneurysm? You do a CT angiogram of the head and neck. And in fact, just as we were, talking about, we were suspicious of an aneurysm with that history. And guess what? We found a 3 to 4 millimeter aneurysm in an artery called the right superior cerebellar artery. And as you can see, this outpouching of the vessel, this is specifically a fusiform aneurysm that is affecting the right superior cerebellar artery. We took this patient for angiogram to better visualize the vessels. And as you can see, this is the vertebral artery that comes and becomes the basilar artery. And then that basilar artery has a branch called the superior cerebellar artery. And in the distal portion of the superior cerebellar artery, you see this pouch measuring in the 4 millimeter range. This is an aneurysm. This is very dangerous, an aneurysm. You need to treat this kind of aneurysms. Well, I guess I gave you the answer already, but of course, every time you encounter an aneurysm, you need to ask yourself the question, what do we do with this aneurysm? Do we just observe? And if we don't observe, do we treat? Typically, you have two ways of treating aneurysm. You can go from within the vessel, which is the endovascular approach, or you can open the head, the skull, and put a clip in that aneurysm to close it. So we discuss all the options with the patient. We discuss all the options with the team, and we decided that the best approach for this one was an endovascular approach, specifically using flow diversion. Flow diversion is a procedure in which we put a flow diverting stent, in this case, a stent called the pipeline embolization device. And you can put this stent throughout the vessel and the stent usually takes care of that aneurysm. So here we have a catheter going through that aneurysm. This is the aneurysm right here, and we have this catheter in this vessel. And here we have opened up the stent, and here is the stent completely deployed. And this is how the patient looks like after the stent deployment. You see that the aneurysm has partially already thrombosed, and this is all through a procedure called flow diversion. This is flow diversion. What is the concept of flow diversion? Well, the concept of flow diversion is that when you have an aneurysm like this is a drawing of a vessel, this is an artery, this is an aneurysm, and this is a side branch of the artery. You will say, why don't you just put a closed cell, a stent in the brain? Well, the problem is that we have side branches, so we have to come up with a stent that will alter the flow to the aneurysm without altering the flow to side branches. Because if you occlude the side branch, you're gonna get a stroke. So what we do flow diversion. What flow diversion does, flow diversion, it slows the blood flow in the aneurysm, but maintains the blood flow in these side branches. So what happens with time is the aneurysm is resorbed while the side branch is completely preserved. And in the end, this is what you see there: thrombosis of the aneurysm and resorption of the aneurysm. Advantages of flow diversion is a relatively safe procedure when done correctly. And of course, it eliminates the need to enter the aneurysm itself, as opposed to coiling, which is the other way we treat aneurysms endovascularly. And the other advantage is that you typically occlude the aneurysm. The other thing is that in an aneurysm like this that is fusiform, if you were to coil that aneurysm, you will occlude the whole vessel. So you would cause the patient an infarct. So by putting a flow diverting stent, you actually preserve the whole vessel. Let's go to another case. We have a 63-year-old female which has mild chronic headache. This patient has some history of fibromyalgia, and a CTA was performed because of these headaches. And guess what? In the internal carotid artery, she had a laterally oriented aneurysm on CTA. This aneurysm was not big. It was only about 4 millimeters. However, sometimes size is not the important thing in an aneurysm. Sometimes the angial architecture of this aneurysm is the problem. So you have an aneurysm that has an irregular teat right here and another irregular teat here. So these are worrisome features that the aneurysm may rupture and cause a subarachnoid hemorrhage. So again, every day on clinical practice, you are faced with these questions. Do you observe and not treat? Do you treat? And if you treat, what do? Do you coil? Do you flow divert? Or do you clip with open surgery? Well, in this case, we decided again to go with flow diversion. And what you see here is the aneurysm. You see the blood vessel. We put the pipeline device again, which you can see the stent lining up the vessel very well. And you see already the partial thrombosis of the aneurysm immediately after putting a pipeline stent. So aneurysm treatment, what are the factors to consider? This is a fairly common thing that we see in vascular neurosurgery, aneurysms. The key thing to start, you need a multidisciplinary team. You need really a group of people who know about each one of the things that we do. We need the neuroendovascular people that know about neuroendovascular. We need the open neurosurgery people who knows about microsurgical clipping. We need good radiologists who know about imaging. We need good neurologists who are able to evaluate these patients well and catch those patients that need treatment. We need critical care people because these patients are going to be treated with stents, coils, or clips and are going to go to a neurological ICU. So multidisciplinary approach is very important. You need to have a frank and open discussion with the patients about all the treatment modalities. And remember, always discuss the risks, benefits, and alternatives of each approach. None of these treatments come with no risks. Every treatment has risk, but of course, no treating has a lot of risks. So we have to discuss and keep the patients well informed of all this. Intracranial aneurysms occur in about 2% of the general population. And in fact, is the most common cause of a non-traumatic subarachnoid hemorrhage. Ruptured aneurysms result in serious morbidity and very, very high mortality. About half the patients overall who have a subarachnoid hemorrhage because of an aneurysm are unfortunately going to not survive the subarachnoid hemorrhage. This is the typical subarachnoid hemorrhage. You have a head CT, and you show all this hyperdensity here, which is blood in your brain. Very important study, that it was the ISAT study published in 2002, which basically showed mortality and disability in patients undergoing clipping, and patients undergoing clipping. And I think that the results were pretty convincing that in the right patients, I think coiling this aneurysm plays a very, very dramatic role, or has dramatic effects in the overall clinical outcome. Let's talk about a few more cases before we're done. We have a patient with hydrocephalus whose status post BP shunt several years prior and has been having frequent falls. And this patient, we scan him, and what do we have here? We have blood again. We have hyperdensity in the CAT scan, but in this case, the blood is not subarachnoid blood. This is blood in the subdural space. We have what we call a subdural hematoma. In fact, in this case, we know that it's a recurring hematoma because we have this mixed density here. We have low attenuating blood and we have high attenuating blood. And of course, this hematoma is producing mass effect and some very minimal midline shift. So what do? Do we observe? Do we do surgical evacuation? Or do we try a relatively new endovascular approach to this case? Is called middle meningeal artery embolization. Well, the middle meningeal artery is a branch of the internal maxillary artery, which is a branch of the external carotid artery. This middle meningeal artery goes into the base of the skull here and goes into the dura, which is the membrane that covers the brain, or one of the membranes that covers the brain. And as you can see here in an angiographic view, this is the common carotid artery. This is the internal carotid artery. And this is here the external carotid artery. If you follow that external carotid artery, you will go here into the middle meningeal artery that goes there into the meninges. So in this new procedure that we do, we can catheterize this middle meningeal artery, go all the way with the microcatheter, and then try to embolize it. And in fact, if you remember from the last picture, here is the internal maxillary artery. This is the middle meningeal artery here. And we're bringing our microcatheter all the way into the distal branches of this middle meningeal artery. This is the microcatheter, which is a tiny microcatheter that we're able to navigate there. And once we are there, we inject something called particles, and we devascularize the membranes that are covering this subdural hematoma. This is the middle meningeal artery. If you look at it here, it's right here. And then here we have embolized this artery, completely devascularizing the meninges. So what happened to this patient? Well, look at the patient 3 weeks later. The hematoma is almost completely gone. Look at it right here. Compare that to this. Look at all the hematoma right here. And look at it 3 weeks post endovascular embolization of the middle meningeal artery. And 2 months later, the subdural hematoma is completely gone. Chronic subdural hematomas is a very, very common disease. Of course, very common in the aging population. So a lot of the elderly people present with these subdural hematomas. Of course, it's more frequently seen in these patients who are on anticoagulation because of heart disease or other conditions. And the challenge sometimes with these hematomas is that the symptoms can be very heterogeneous. These patients can be, either having headaches, or they can have, various symptoms like a speech impairment, gait instability, seizures, or even sometimes focal neurologic signs. There are, unfortunately, right now, no established guidelines for this, although I will tell you that we are right now at the moment starting very important clinical trials for these hematomas. So hopefully we'll soon have, more understanding into their natural history and so on. But the bottom line is that traditionally, the treatment for these hematomas have been evacuation by doing burr-hole or craniotomy, and we evacuate these hematomas with the problem that sometimes, despite evacuation, these hematomas recur. So these patients come back with more hematomas, and then we've had to, submit them to more surgeries. With this new, technique that have, come out in the last couple of years, we treat them endovascularly, and so far, the failure rate of this, new technique has been pretty low. So of course, it's a relatively new procedure. So we need to give it time and see how these patients do over the long term. And hopefully new clinical trials that are, undergoing will give us more insight into the real long-term prognosis and long-term, outcomes of these patients undergoing these procedures. All right, so we have now another case of a 65-year-old female who had sudden onset of global aphasia. This patient has a past medical history of congestive heart failure, living in a nursing home, but at some point, very, very sudden onset, very clearly onset of global aphasia. Aphasia meaning that the patient cannot speak, cannot understand a single word that you're telling them. The patient also had left gaze deviation, meaning the head of the patient was turned towards the left side and had right-sided weakness. The patient was last seen normal at 6:20, as I said, and was brought by EMS to the emergency department. So what am I showing there? I'm showing a CT perfusion scan. What you see in green is the area of decreased blood perfusion in the brain. And what you see in this purple color is the area that has infarcted. What we look at, the way we look at these scans, we try to do a match, or in this case, a mismatch between the infarct and the area of perfusion defect. When you see a scan like this that has a relatively small infarct, but a large area of perfusion, we say there is a large mismatch, which means there is a large area of the brain that we can save. So, as expected, this patient had a clot occluding a blood vessel in the brain. This is an acute stroke. And this patient got a clot busting medication and then transferred to us for a procedure called thrombectomy. If you were there a few weeks ago, I actually took you to a whole case of mechanical thrombectomy, and I explained to you how we did it. So in this case, the patient had a thrombectomy, which, a clot here that we completely recanalized, and the patient did very well. A stroke, as you may know, is a fairly common disease. Basically, it is the number one, it is the fourth leading cause of death in the US, but more important than that, it is the number one cause of adult disability. So, curing a patient with a stroke really can make a big difference in patients' lives. It can be the determining factor between either the patient spending 20, 30 years in a nursing home, not seeing their families, or just being dropped, significantly disabled, versus spending your life, having a functional life and having, a life that you can enjoy daily things. Causes of a stroke, many causes, but the big ones are going to be atherosclerosis of the head and neck, and of course, cardiac arrhythmias just such as atrial fibrillation, among other, causes. And of course, as I, explained to you in details in a few weeks ago, the field, has taken a drastic turn since, a few years ago, when a lot of the trials came out, thanks to the dramatic evolution of technology and, you know, the advent of really good catheters that allow us to go into the small blood vessels in the brain, and we've been able to then retrieve those clots very efficiently, very quickly, and very safely, so that giving the patients, you know, outcomes that we were, you know, or that were unheard of just a few years ago. So as you can see from this graph or from this, you know, slide, this field is rapidly evolving. Just in the last few years, we have an enormous amount of, you know, of technology, of enormous amount of innovation. So the field is, you know, evolving as we speak. And I will tell you that every, you know, other month we come up with a new technology, and we're always, you know, very excited to test these technologies. Of course, you always have to be cautious as well with the technologies, because not all the technologies are good, but I think overall we have seen a dramatic improvement. So summarizing, I think the take-home message from here, I think from this virtual OR today, you have seen a broader spectrum of cases. You have seen ischemic cases. You have seen cervical, you know, carotid cases. You have seen some aneurysms, some brain bleeds, some subdural hematomas. I think in our field, as in a lot of, you know, different medical fields, but probably, you know, I tend to overstate this, but I don't think it's an overstatement. I think this is, you know, something I always tell everyone. The devil is in the details. When you have patients which are sick, you know, pay attention to details. You know, the initial imaging may be normal, but as you really dig in, you know, the causes, and you really do more workup, you will find the causes sooner or later. And, you know, the more we look, the more we find, and the more we find, the more information we have to take the right decisions for patients. This is a very, you know, tough field in a way. You know, making decisions many times means whether a patient will be alive versus a patient won't survive, or whether a patient will be, you know, neurologically intact or will be significantly disabled. So sometimes we have very, very little room for mistake in our field. And then you have to really pay attention to details and do an extra effort and try to understand what's going on. When you understand things well, or in a good way, you have, you know, more information to take the right decisions. The other thing, as you have seen here, it's important to be part of a team. You know, have great partners. As we speak, I have a great partner in the background right here, the famous Dr. Danilo Silva, who's in the back, who you probably know from other talks. And we have an extensive team with Dr. Langer, Dr. Ellis, Dr. Ortiz, and you have to tackle, you know, these diseases as a team, because, you know, we all have to sort of, we all see our things from our, you know, from our own very, very, you know, individual subspecialty, but we need to really, you know, approach this with, you know, everyone on the room and discuss each case. And that's what we do, in fact, every week. We sit down every week and we go case by case, and we try to arrive to a consensus. And finally, which is, I guess, you know, something that, you know, you take from here, is that teamwork is everything. There's no I in team. Teamwork is, you know, everyone in the team, you know, plays a fundamental role, you know, from the, you know, office staff, from the person in the ED receiving a patient, you know, the nurses, the PAs, the doctors in the ED, the techs in the OR and in the angio suite. I think everyone in the team is fundamentally important, and we have to be, you know, pay attention to that, because we have to rely on the fact that everyone is doing their work. And in order for these cases to be successful, everyone has to be responsible for a piece of that. So when you have a good team, you typically have good outcomes. So it's been a pleasure again. It's great to share these cases with you, and I hope that, you know, by now you are excited about, you know, medicine. You're excited about saving patients. You're excited about, neurosurgery and neuroendovascular specifically. And, you know, if you have questions, I'm happy to answer the questions. I'm also happy to answer them offline. Just follow me or just shoot some questions, and I'll take any questions. Thank you very much.
I'm gonna open the chat up real quick if you want to take a look at that.
Okay, let me see. Okay, let's see. Where's the chat now? All right. We have a lot of questions. Sure, I'll put my email on the chat. Okay, there's my email. If the balloon is overinflated, can it cause the artery to rupture? That is a great question. That is a very good question. And I think those are the things that we are worried about. Ballooning a vessel is no trivial thing. That's why you go to training to do these things. When you balloon a vessel, you have to be extremely, extremely careful. You have to have 4 eyes at least on that screen, and you have to do it very carefully, not only looking at the screen, but feeling your hands as you're inflating the balloon, assessing for resistance, and you're gonna go very, very careful with that. So extremely important thing to have. You have to be very, very careful inflating these balloons. When do you use coilings for an aneurysm? Great question. I think aneurysm treatment is a big, big thing in the field right now, because we don't only have coilings now. We have a plethora of devices right now, including flow diverting devices, including stents, including new coils. So the plethora of technology is growing every year. So first of all, we have to be very familiar with your technology. You have to understand how the technology works. You have to really dig in and understand the engineering behind your technology. Then you have to understand the disease well. Then you have to look at the data that's out there. And then you have to have great partners to sit down and consider all these options. I don't believe in taking unilateral decisions in these cases. I believe you have to discuss with your colleagues and then discuss with the patients all the pros and cons. So coilings, you know, as I said, it's a part of the plethora. Very broadly speaking, you will use coiling in those cases that are, you know, aneurysms that have a very small neck that would allow you to put coils. But, you know, always a subject of discussion. Let's go through some more questions here. Any advice for an upcoming first generation student solely interested in radiology? How should I go about finding a mentor, research, in particularly neuroradiology? So if you're a med student, I think if you're a first year med student, my only advice would be keep your options open. I get it that a lot of us go into med school already knowing something, but I would say keep your options open, talk to people, do your rotations. I'm not trying to dissuade you to going into one field or the other. What I'm saying, wait until your third year probably, that you have gained more understanding into your rotations. And once you rotate, you're gonna have a better idea. Very important thing, and you mentioned already how, you know, you need to find good mentors. Mentors are gonna be a big deal. And I'll tell you, it's not only in college, it's not only in med school, it's gonna go on the rest of your life. As we speak, I have great mentors. I've had great mentors, and mentors make or break a career having a good mentor. So yes, how do you go about finding one? Talk to people. You have to be, you know, you have to talk to people. Don't be shy. Approach that when you're a med student, approach those attendings that you think, you know, you admire, that you want to be like, that you see yourself in. You know, I think it's always important. When I was a med student, I always, you know, thought about, you know, I want to be like this person, or I don't want to be like this person. And it's not that you're going to be like the person, but at least it gives you an idea of how you see yourself in 10 years, in 15, in 20 years. So look at those people that you look up to, approach them, and don't be shy. People, you'll be surprised. People love to mentor, and as much as you love to be mentored, people love to mentor. So don't be shy. Let's see. We talked about that. Can you please talk about your path to medicine and why you chose to pursue a PhD? Great question. So my path to medicine was, driven mostly by science, to be honest with you. So, I read a lot of neuroscience when I was in pre-med, and I felt very, very excited about understanding how the brain worked. That was my main focus. After talking to a lot of mentors, I was, advised that, there are many ways to get to the question that I wanted to ask to answer, and I pursue, an MD and a PhD degree. As I advance in my career, you have to keep your options open, and that's what I always tell people. I kind of like went about different ways. At some point, I thought I was going to be a researcher, but then at some point, I realized that my passion was to go into people's brain and try to save them, and that's how I went about. This is, of course, very simplified. It's a lot more complex than that, and that would probably require another hour just of chatting of that. But I think that the MD PhD is a great path, but challenging, very challenging. It's very difficult to combine both clinical medicine and science. And I will tell you that right now, I'm 100% clinical person. It's very hard to find a combination of both. It's not undoable. In fact, it's totally doable, but it's very challenging. But great question. Let me see if I can answer a couple more. How do you use codes? I think we tagged that. Is reperfusion injury a significant problem after mechanical thrombectomy? Absolutely. When you open up a vessel, there's always the concern that you will injure the vessel. In approximately 4 to 10% of cases, in fact, you will have the risk of causing reperfusion injury. Great question, this one from Camille. How do you see potential for better drug therapies in preventing aneurysm? Well, look, listen, if you come up with a drug that would prevent aneurysm rupture, I think that's a very, very big deal. Of course, we don't have it right now. So unfortunately, we don't have it, but I think that's a great subject of research. So I'll tie this question up to someone talking about how an MD PhD can go together and how can you help advance the field of endovascular, neurosurgery and neurointerventional radiology. That's a great question. And I think the future of the field relies on research. There is no question. There are many types of research. There's clinical research that we could do with patients, but there's basic science. And alluding to the question, can we get better drugs? Absolutely, we can. We every year come up with different drugs for different things. We have to think outside the box. We have to always question everything you see. The same way you question your cases, you have to question science as a whole. And I think that sooner or later, all of these fields are going to tend to be less invasive, and there will be a time probably that we won't even need intervention. We'll just rely on medications, on targeted therapies, gene targeting therapies, receptor-based therapies, understanding which receptors are present in certain molecules that we can target. So, I think that's where the future of the field will be. For a stroke, for neurovascular protection, how do we protect the brain from getting infarcted when you don't have sufficient blood flow? Yes, we can get the clots out right now, but the brain still dies sometimes. So how can we take the clot out, but at the same time protect the brain from dying? So all of these things will require multidisciplinary teams, will require a lot of research. And I think that's when you guys come into play, choosing smartly, and being very ambitious. You have to be ambitious. You have to think that you can cure diseases and you can do all this. What is an underestimated skill that is necessary to be good at this? Well, I think that the worst skill that I think I can think of right now is to be overconfident. When you think you know the stuff very well, never be overconfident. The interesting thing is that this is nothing new, what I'm saying. If you read any book, if you read any finance book, if you read any leadership book, if you read any science book, it's always going to be the pattern of always have your doubts. When you see things happening, ask yourself, wait, take a step back, ask yourself, what about if I'm wrong about it? What can go wrong? And we face that every day in our procedures. Yesterday, I was coiling a very challenging aneurysm, which I didn't show you today, but hopefully I can show you in another moment. And when we put that first coil, it's very important because several things that can go wrong. We can rupture the aneurysm by putting a coil. We can size it in a way that when we deploy it, it can actually go out of the aneurysm and occlude the vessel and cause a large stroke. In fact, multiple things. So when you are coiling that, when you're putting that first coil, you have to select very well the size of the aneurysm, the size of the coil. So when I was putting that coil, I stopped and I said, okay, let's assume that my decision was wrong. What would happen? It could rupture, it could do this. So you have to ask yourself, what about if I'm wrong? And then be sure of the decision and then take a step back and then come up with the decision that you think is better. But always, always, never be, overconfident. What are your thoughts on a three-year MD program? I think the 3-year MD programs have been coming up. I think NYU had one, and there are a few other schools. I think it's great. I mean, listen, if you can do it in 3 years, I think it's great. I just can't comment really on the curriculum and so on. I will tell you, take your time in things in general, because it's not all about being done quickly. It's about being done right, but also enjoying the way and enjoying the travel. When I look at my years in education, going through an MD, a PhD, residency, as many years as that goes, it's not really about being where we are right now as an attending physician. It's really about the route to get here. So cherish the moment. Don't forget about that. Your best years are going to be those years where you're training, as hard as they are, try to enjoy them. The friendships you're going to make, the experiences you're going to have, those things don't come back. And, just try to enjoy the moment. That's my advice there. What was my PhD thesis on? It was actually on learning and memory. So I was actually trying to understand how the brain worked, and that had further ramifications in neurotoxicity. By going into that, we started digging into neurotoxicity and trying to understand how some excitation in the brain through AMPA and NMDA receptors lead to toxicity in the context of acute stroke. So very interesting topic. Reach out to me if you want to learn more about that. So do you feel you learn every moment of every day? Is each patient's anatomy and disease unique? And I'm probably going to finish with that question. And the next one, which is, how is your work-life balance and how do you establish healthy boundaries between the two? Okay, I'll try to answer these questions in 5 minutes. How do you feel? How do you learn every moment, every day? Yes, we learn every moment. I've been several years in practice. I went through a lot of training, and you will be surprised to know that sometimes, yes, every week we encounter new cases that are new to us, that is not described in the literature. And that is great because that keeps our life super exciting, our professional life. That keeps us going to work super exciting. and that keeps us going forward. And we learn not only from cases, we learn from our colleagues. As I said, surround yourself with good people. Surround yourselves with good partners. You don't want to be sitting to a person who is gonna, not add to what you do every day. You want to be surrounded by people who are good, who are inquisitive, who want to advance and want to progress with you. How is your work-life balance? Well, you need a work-life balance. There's just no other way. Otherwise, you won't have a nice life. How is mine in particular? I can tell you about mine, but each one has to find your own path. I have a family, I have a wife, I have 3 kids. I try to, have time with them. Of course, our life can be tough. Yesterday, I left my house at 6 a.m. and didn't come back until almost 9 p.m. So that means that then today, when I get there, hopefully at 4 p.m., I'll be able to do something with my kids. I'll be able to chat with my wife, and we'll be able to do things. We love to travel. We try to travel several times a year. We try to pick new locations to keep things interesting, and we enjoy planning those trips. Myself, I try to work out several days a week. I love working out. I love getting up early and having a good sweat. And I'm doing, high intensity interval training sometimes weight training. I try to convince my partner in the back here, the man, the myth, Dr. Silva, to come with me, but I think he's just too good in basketball, and he doesn't want to do the kind of stuff that I do. But listen, the bottom line, you need to have a balance. Have friends, family, have fun, work out, be healthy, lead a healthy life. Don't get yourself in that thing that, med school is going to be tough. Residency is going to be tough. PA school is going to be tough. Nursing school is going to be tough. But don't get yourself in that, maze of just working. You need a balance. You need to be healthy, to be able to work well as well. So it's all together. I think we're really on top of the hour here. Let me know, hit me on Instagram, and I'll be able to answer more questions. It's been a pleasure.